Thank you, Mr. Chairperson, for the kind introduction, and I'd like to thank Materialise and the organizer for the invitation to speak today. Indeed, this is an honor to be here, to be in a crowd of not just pure physicians or pure cardiologists, but people from the industry who understand the technology way better than I do as an end user. I have no disclosure of any conflict of interest, but I like to make a disclaimer. Again, I am not an engineer. I have no idea how additive manufacturing works. All I do is just I call up Materialise, I need this done, and they will produce a heart model for me and to show it. So thank you once again, Materialise, for the immense support that he has provided. We all know that the medical uses of 3D printing are vast, and it continues to expand. And broadly speaking, can be categorized into actual as well as potential applications. The actual applications of 3D printing in medicine are found in the creation of 3D printed prostheses that can be customized to individual patient needs. In addition, we can also generate anatomic models that are accurate and exact replicas for patients. And I do not need to preach to a crowd that are really converted about the utility of 3D printing in medicine. I was given the task of sharing my perspective as a clinician on how 3D innovations, how it delivers benefits to patients as well as the hospital. So to my mind, the hospital is just a building that consists of a lot of people, at the center of whom are our patients, who sit at the heart of what we do. And as a pediatric cardiologist, the child's always first. And from my perspective, I think the best way of demonstrating how 3D printing has delivered benefit to my patient care is through the demonstration of a patient's journey. And I'd like to show you at the end of my talk that 3D printing has indeed added value to our current practice of pediatric cardiology. Our story begins with baby A, who is currently a 6-week-old baby boy, and who was diagnosed with a complex congenital heart disease. And as the term implies, it is a complex congenital heart disease. The diagnosis in itself, however, does not lend much insight or information of what we need to do for the patient. And baby A was diagnosed antenatally in the womb with a complex congenital heart disease. Hang on. Could you just help me play the video, please? I don't see it. Are you able to help me click on the videos to let them play? Anyway, on the panel to the right, you can see the antenatal ultrasound that most of us are familiar with. That we could see that the head of the baby is here, the chest and the abdomen, and the heart sits in the center here. It's supposed to play and beat. If they could help me just click on it. But this is just a two-dimensional methodology of looking at a three-dimensional structure, especially in the context of a complex congenital heart disease. So what we do is actually to build a three-dimensional picture in our brain by having multiple slices of the two-dimensional ultrasound beam looking at it. Unfortunately, it wouldn't play, I believe. Sorry about that. But this patient was diagnosed with a condition called double outlet right ventricle. And this particular anatomy lends itself highly useful for us in terms of approaching this condition and the anatomic and surgical repair. Why is that so? Just quickly bringing us through the structure of the heart so that we can understand better why is it so important to understand the relationship of the double outlet right ventricle. Anatomically, the heart has 4 chambers divided into the right side and the left side, and the deoxygenated blood has been used that will pass through the right atrium to be pumped by the right ventricle to the lungs to receive oxygen. And this oxygenated blood will then return to the left atrium to be pumped by the left ventricle to supply the rest of the body with oxygenated blood as well as nutrition. Now, in double outlet right ventricle, we can notice that the right side of the heart and the left side of the heart each has 1 inlet, but the right side of the heart has 2 outlets, namely the pulmonary artery and the aorta. But there is no outlet from the left ventricle. And it is fortuitous that there is always a presence of a ventricular septal defect or a hole in the heart to allow blood from the left side of the heart to be drained out into the body. And hence this results in cyanosis or bluish discoloration of the patient because the deoxygenated blood and the oxygenated blood now are mixed in a single chamber to be pumped to the main bodily circulation. And this causes the oxygen level to be low in the range of 80 to 85%. Now, if I were to tell the patient's parents that the child has complex congenital heart disease, in their mind, okay, fine, that is a diagnosis in itself. But the detailed diagnosis is one in which we will call it, besides a double outlet right ventricle, there is a discordance of the atrioventricular connections. What does this mean? To add complexity to this particular condition is that the right and the left ventricle are now inverted, are switched around. The right ventricle, instead of being on the left, being on the right, is now on the left, and the left ventricle, instead of being on the left, is now on the right. And to complicate matter further, the great arteries, meaning the pulmonary artery and the aorta, are now transposed, meaning the positions are also switched around. So the task in our head as we do an ultrasound for this patient is to come up with a diagnosis and process it in our brain, to come up with an accurate anatomic diagnosis. And once an accurate anatomic diagnosis is generated, we can then communicate this with the surgeon, who can then decide on the exact and precise surgical approach. And this is, again, if you could just help me click on this image panel and see if it would play. And this is the routine way of our current modality for the diagnosis of congenital heart disease using ultrasound. It's a two-dimensional imaging modality in which that we can see that two ventricles. This is supposed to be the left-sided right ventricle. This is the left-sided right ventricle. And from this left-sided right ventricle, there are two outlets, the aorta and the pulmonary artery. And one can argue, just basically looking at this two-dimensional plane, is it truly a double outlet right ventricle, depending on how we draw the line. If this is the ventricular septum, if I cross it up here, there will be one outlet from the right side, one outlet from the left side. Or if I draw the ventricular septum all the way here, then truly, then this is a double outlet right ventricle. Is subject to a lot of argument between cardiologists who just look at two-dimensional pictures. But this is highly pertinent to the surgeon because they need to know how to approach this surgically. So we are highly aware and the acuity of the need for three-dimensional imaging in our brain as we process this in our head and then to communicate this with another physician. And 3D echocardiography has made significant improvement in trying to improve the image resolution for us to see that this is the left ventricle, this is the right ventricle, and there are two outlets, the pulmonary artery and the aorta. But as you can see, the image resolution is limited. And number two, I cannot manipulate this data any more than it is displayed on a flat 2D screen. So therefore, virtual demonstration of 3D structures on flat 2D screens, although facilitate understanding, we can now appreciate why 3D printing takes a closer step towards reality by having us a physical model in our hands and to understand the anatomy. So this is what we usually do. Having done the imaging for the patient, we subject the image data through a segmentation process to convert the DICOM data to STL format so that we can feed it into the printer to generate out the 3D printed models. The most common modality that we use are either CT scans or MRI. Ultrasound currently have its own limitation owing to its limited image resolution and to the size of the heart that I can capture within one single ultrasound image. Based on this MRI data, we can see that the entire heart can be covered and hence generating a printed heart model. And I can design it in various ways, either giving us a hollow model or a blood pool. And blood pool is particularly useful for us to evaluate the blood vessels if there's any narrowing, which can be usually a bit difficult to see on a hollow model. And just based on this 3D depiction of the congenital heart disease, we can see that the left ventricle here, which is smooth, is lying on the right side. There's a huge hole right in the center of the heart and an atrial septal defect. And again, this is not very useful if I were to just speak to the surgeon. Once we print it out, the surgeon is able to hold it in his hand, appreciate the three-dimensional profile of this congenital heart disease, and that leaves me with no word. Current practice is that we would present the findings to a surgeon on a flat 2D screen of the echo imaging and trying to convey a two-dimensional picture in my brain and then transmit it to the surgeon's brain, and hopefully the surgeon sees it in 3D and approach the surgery intraoperatively, knowing what to do, and we hope, right? And oftentimes when it comes to complex structures, our surgeons have gotten back to us and said, you know what, there's a little bit of an aberration to what you have said. And so, did I say that? Because sometimes miscommunication happens when we use terminologies that are diverse or inaccurate or even controversial. So by having a model in the hand, it requires no further explanation using vague terminologies. And we can then divert our attention into truly doing what is necessary to fix. So besides just improving the anatomic diagnosis, we can then improve communication with the surgeon. And the communication, as I mentioned earlier, is particularly difficult. And this is Dr. Nakao, who does most of our patients with complex congenital heart disease. And he would then look at this model, ignoring completely what I would tell him, and looking at the heart model, and tilting it in any way that he wants. He can manipulate this model in any way that he wants to view the outflow tract of the heart. And truly, in this case, this is truly a double outlet right ventricle, because we can see that this is the left-sided right ventricle, the large ventricular septal defect, the hole in the heart, and two outlets coming up from the same chamber. And if I were to just look at it, the surgeon will then appreciate the uphill task that he has to close this hole, and not to just only close this hole in a flat patch. The patch has to extend all the way across to cover the aorta. And it's no longer a patch that the surgeon will have to use. It will be a baffle from the ventricle on the other side to direct blood into the aorta. And this is looking upwards to look at the outflow tracts. And all this improved diagnosis and improved communication leads to one thing: improved patient outcome, specifically improved surgical outcome. In congenital heart surgery, most of our patients' hearts are the size no bigger than a large strawberry. And so the surgeons even have to wear loops in order to magnify the surgical field. And can you imagine if the assistant would have to assist the surgeon in the process of the surgery? There's very limited access and view to the surgical field. And having the heart model in their hands prior to the surgery, they can talk it out and they can do some surgical pre-planning. In addition, they can also use the 3D printed heart models using flexible material to even practice the surgery prior to the actual operation. And this is the surgery that this patient would need. It needs a closure of the hole that would include the aorta, and a conduit that will direct the blood from the right ventricle, which is now on the left side, to the pulmonary artery. And this is completely something that we would not be able to imagine if you just see it from a two-dimensional point of view. In this day and age of modern medicine, it is not just good enough to deliver excellent outcomes. With our patients who are more educated, they demand more, they expect more from us, and they would like to be directly involved in the decision-making process. And this is a good thing, as a reflection of true informed consent. Now, traditionally what we do is to draw out the hearts on a piece of paper in 2 dimensions, trying to explain to them what's going on and what to expect during surgery. I remember having this heart printed out thanks to our local industry collaborator on an urgent basis, and I could use this heart model, open up the heart, showing the parents where the holes are, and to show them the uphill task that the surgeon has to take in order to fix this congenital heart surgery. And finally, they understood in their head, why is this surgery such a high-risk procedure? Because it's not just simply closing the hole in the heart, but it involves tunneling and baffling blood flow and putting another conduit to shunt blood into the pulmonary arteries, an operation that would take a couple of hours and is highly risky. And with this, the parents would truly appreciate what we do, and it makes the communication process so much easier and expedited. Just before you go away thinking that whatever we do is always peachy and heroic, I'd like to share a second patient in whom the outcome is less than happy, but yet it was a good outcome nonetheless. And this is another complex congenital heart disease in which there's pulmonary atresia with ventricular septal defect. What it means is that there is no communication between the right ventricle to the lungs. It is not formed, unlike a normal heart. So in order to channel blood through the lungs adequately, the body develops smaller blood vessels, what we call collateral arteries, to supply the lungs, to bring blood to the lungs. Now, what the surgeon needs to do as an initial stage of surgery is to bunch up all these blood vessels together to form good-sized pulmonary arteries. Now, provided they are nice and big in caliber for the surgeons to be able to fix them together. We have this patient who was also diagnosed in an antenatal period with pulmonary atresia with ventricular septal defect and major aortopulmonary collateral arteries. And once the patient was born, we did a CT scan to look at all these blood vessels and the size of which they are. When we first looked at it, in collaboration, the cardiologist and the surgeon decided that this is way too high a risk of procedure to be performed because they are so small. And if we were to open them up, stitch them together, they will probably just narrow down and will not work, and in essence killing the child. Now, having done all the tests, the parents were very insistent on proceeding with the surgery and having a full corrective repair for the child. So what I did was I then printed out the heart, and this is a double magnification of the child's heart and showing the parents how small these blood vessels are, and to help them appreciate if we were to do something to these blood vessels, they are likely to narrow down and not work, and hence essentially killing the child. And I'm pleased to report that the parents in the end decided, along with our decision-making process, that we would manage this conservatively. And thankfully, the parents had 6 months of time with the child rather than subjecting the child to surgery within the first week of life, and ended up having us probably effectively killing the child. Now, going beyond delivering benefits to the individual patients, there are also benefits of 3D printing to the hospital. The second pillar of what we do in a hospital is to educate. And I remember those days as a young trainee in cardiology, I always struggled with imagining what the hearts would look like in 3 dimension. And this is supposed to be a video of showing how we learn cardiology. We have to fly all the way to either to the UK or to North America, where traditionally we can use pathological specimens that are removed from patients after they have died during the procedure of autopsy or even during heart transplantation to teach us cardiac morphology. But with the advancement in surgical technique and medicine, more and more of these patients are surviving, and pathological specimens are becoming scarce for us to learn. So what better way than to print out the hearts? So when my surgeon came up to me and mooted the idea of conducting a course on cardiac morphology, I said it cannot be done. In Singapore and in our part of the world, organ donation is rare, and consent for autopsy is even rarer. And it's virtually impossible to get models for us to learn and to conduct a course. And lectures and just slides alone would not make the cut. But my surgeon was persistent and continued to nudge me along and see how I can fix this shortcoming. And I thought about the idea and said, hey, why don't we just print out the hearts of our real patients? And this is our inaugural cardiac morphology workshop that was highly successful, that attracted many participants from the region, in the Asia-Pacific region. And the feature of the morphology course was the use of heart models that are printed out. And besides being able to demonstrate this on the screen, the participants also had hands-on sessions to look and feel and play with the models, and making a very good substitute for what we lack. Simulation can be extended to surgical practice as well, where the surgical trainee can be taught on how to do the surgical procedures before even graduating to perform it on real patients. I'd like to move on then into the potential applications of 3D printing. We know that 3D bioprinting is very useful when we use living cells from the patient to create tissues or even hold organs. But I am a transplant cardiologist, and we know that skin has been generated for burn victims. We know that organs have been printed out, the kidneys, the ears, the bones. But for the heart, it remains challenging. As a transplant cardiologist, organs are always hard to come by. And there are more than 20 over patients waiting for a heart in Singapore. These are adults. And the ministry has recently approved a pediatric program to allow us to do transplant for children with heart failure. But we know organ donor shortage is always an acute problem. And where do we find them? Somebody has to die and donate the organ before a transplant can happen. And we also know that children have the highest wait list mortality while waiting for a heart. They don't have a lot of reserved weight. Now, this is something that I thought would be more or less science fiction, but having returned from San Diego recently at the International Society for Heart and Lung Transplant Conference, I've noticed that tremendous advances has been made in terms of tissue bioengineering, that people are able to print contracting heart muscles. The limitations are to print the heart valves, to get the vascularized heart will be even harder. I imagine that in the next 50 years, we will be able to print the heart. And we once used to joke, we can't buy organs from the shelf. But with the advancement in this kind of technology, I would imagine that one day, truly, we can actually buy organs off the shelf without needing for organ donation, without the need for immunosuppression or even long waiting time. However, there are limitations. It is time consuming, and the printing will take time. And printing that one patient's heart alone would have cost me $1,500 US. And just before we go away thinking that everything is nice and bloomy, but there are some limitations which I believe can be overcome in the near future. And in conclusion, 3D printing has found its niche applications in the medicine of congenital heart disease. It's highly useful for people like us who needs to imagine and to communicate our imagination so that somebody else can imagine it once again and see what can happen before the surgery. It allows instantaneous and precise understanding of any complex structural heart anomaly. And it has made a small revolution in the field of simulation training as well as surgery. And this will open the door truly to a new era of personalized medicine. And with this, I thank you for your attention.